Our next speaker is Dr. Christopher Kahn, and he's here representing the California Hospital Association today, talking from that perspective. Dr. Kahn began his medical career as an EMT, basic for Stat Ambulance here in San Diego. After completing his formal education and spending 2 years as a medical fellow for the Office of Emergency Medical Services at the National Highway Traffic Safety Administration, he joined the faculty of UC Irvine. He is a member of the DMAT team, CA4, and serves as a reviewer for several journals, in addition to serving as an EMS section co-editor for the Western Journal of Emergency Medicine and the section editor for NHTSA's notes. So with that, we introduce Dr. Kahn.
Excellent. So, hi, I'm Chris. Now, I apologize. I know it, according to the program, it looks like my name should be Stacy Elmer, and I do apologize. But we switched things up a little bit because I do have a shift I need to get to later. Work never stops. So, this section of the program, we're talking about different stakeholders and their perspectives on community paramedicine. And I definitely want to sort of make clear where I'm coming from up front. I am a base hospital medical director for one of the 7 bases here in San Diego. You can probably guess which one. It's down there, the right lower corner. So I'm coming from the standpoint of an ER doc who's also EMS board certified. I am an active participant in the San Diego Fire Rescue Community Paramedicine Project and have more than a passing familiarity with the Carlsbad Project as well. But my perspective that I'm presenting here today is the hospital perspective. I was invited to speak by the California Hospital Association. Thanks very much, and I hope you don't rescind that invitation in about 20 minutes. So from that standpoint, let's go ahead and talk a little bit about that world. Because the problems in my world, and there are always problems, it's pretty similar to what everyone's been talking about, right? Emergency department crowding, patients coming in, how do we get them out? Say, maybe hypothetically 91 hours for a psych patient. And we've got these acute care resources that we're using in all of these patients with chronic problems. I said I'll be on shift in about an hour and a half, and the chances that I'll see someone with either alcoholism or a substance abuse issue or a psych illness are probably greater than 0%. Funding is certainly a concern, right? You never know where the money is coming from. And due to all the problems, we get a lot of complaints. First, our patients are complaining. Usually the main complaint is, what on earth is taking you so long? Some version of, why hasn't anyone talked to me? Why have I been in this waiting room for 5 hours? You guys admitted me 6 hours ago. Why am I still in a hallway bed instead of in a nice private room upstairs? And you can imagine that list goes on for a while. But they're not the only ones that are complaining, right? So from a hospital provider standpoint, we're now, of course, I won't officially tell this to my administrators, but why doesn't the administration understand what is going on down here? You saw Matt's video earlier from ZDog trying to explain to a hospital administrator just exactly what your concerns are, and sometimes it doesn't always seem to translate very well. Why do patients keep coming in with those same complaints? I just assessed and discharged you in the last 45 minutes. Why are you back? Why are we seeing the same people all the time for the same things? And a lot of it comes down to, why don't I have any good options, right? If I need to get someone to housing or I need to get someone to detox, that's tough to do. And I have a social worker and a case manager, not 24/7, but even when I have them, it's tough to do that. But, again, complaints come from everywhere. EMS providers, it's a lot of the same questions. Why are we seeing these folks all the time? But then things that, from a hospital standpoint, we don't always think about as much. And as a base hospital director, it's not uncommon for me to get something, hey, what happened to that patient? I'm like, well, call me anytime. I'll happily tell you. But I'm one of the only feedback mechanisms that they have. They can't just power on their EPCR and bing, the outcome for that patient shows up a couple days later, which makes, quality, outcomes improvement, that sort of thing, and just knowing what the heck happened, quite difficult. And then the questions that we get all the time, why do we always end up waiting, for hours to offload patients at various hospitals that I'm not going to name? Please don't be mine. And why are we sitting on the wall if there's empty beds? Now, the administrators, they have their own concerns. And to be fair, it is obviously a difficult thing to keep such a complex operation running. And they want to know how they're going to do that. They're getting these costs imposed on them. They're getting lots of penalties that we've discussed. The hospital readmission reduction program penalties. Soon the pay for performance thing should be finalized, or sounds like going to be some issues with that. How do you maintain that market share? How do you balance your staffing versus, the need to keep things under control so that maybe you're not wasting those human resources? And again, why can't we just discharge someone if I saw you 45 minutes ago? So I sat there and I realized, I could complain all day. That's something I'm going to pretend I learned from my kids, but it's probably the other way around. And really, when I'm trying to put this together, I end up thinking about this in terms of what are the outcomes? What actually matters? How should we be looking at things? Because you got to have a metric or you're not going to know how to measure what you need to do. And we're all familiar with the, the triple aim, Don Berwick, the Institute for Healthcare Improvement, that sort of thing. But I'm an EMS guy, and I like going back to the EMS Outcomes Project, which is, almost 20 years old now, and looking at the 6 Ds, the ways of figuring out what is it about each condition we might be studying that we really need to pay attention to. Death, disease, or some alteration in your physiology, disability, discomfort, like your pain scores, dissatisfaction, and destitution, which is so much nicer way of saying, wow, you're broke. And ultimately, we all know what the outcome is, right? Right care to the right patient at the right time, the right place. So great. How does community paramedicine, and from the hospital standpoint, how does this fit in? Does community paramedicine even address those? Well, sure. As we've been discussing all day, you get a paramedic out there, and they're pretty good at figuring out if someone needs resuscitation or a refill, or something in between. As far as we're concerned, every patient's the right patient. You called us, we'll see you. The right time. Some of these patients need to be seen immediately, some maybe later this week. Some of these patients, as we've discussed with the post-acute care patients, maybe they need to be seen before they actually ask for help. And that's something that hospitals are traditionally not that good at, because we don't usually go out and just drag people in. I think they call that kneecapping, and it's fraud. And then where's the right place to see you? Is it the emergency department? Is it detox? Is it the patient's house? Maybe it's jail, which sounds harsh, but there's a time and a place for that as well. So before we think, should we have someone else do this? Well, can hospitals do this? It would be good to know before we start thinking about making other plans. So can hospitals provide the right care? Well, of course, right? All hospitals can do some things. A few hospitals can do pretty much everything. Some hospitals are better at some things than others just because of the specialists they have available, or, they have this piece of equipment or not. But chances are we are providing some patients with a little bit too much care, especially if we don't know you that well already. And it turns out, like we said, some hospitals may not have that specialist that you need. Oh, I'm sorry, you need a left eye retina specialist. We only specialize in right eyes. So although we can do right care, I don't know that the hospitals automatically are the best at doing that. Right patient, again, will care for anyone. We do prefer to keep people on their home health systems, largely because we know you better. The right time, well, the ED is always open, right? Great. But sometimes it's busy. By sometimes, I mean essentially all the time. Our clinics can get overbooked. Sometimes the specialist you need isn't a doctor, which is hard for me to admit as a doctor, but there are times where I can do essentially nothing for someone that, a very talented social worker, a case manager, you know, physical therapist can do beautiful things for this patient. We don't really have those quite as available. There are not a lot of 3 a.m. physical therapy consultations anywhere I've ever worked. And the right place we can already figure out. But again, if you're already at the hospital, then we're figuring out post hoc. That's after the fact. So that's the hospital standpoint. Can community paramedicine do this, right? Is community paramedicine our white knight to the rescue, or is it a way of not helping so much? The EMS part of me says, well, of course this helps. And the hospital part of me says, well, we should at least take a look, right? Everything works better based on thinking things through. Don't worry, I do like community paramedicine. So from the hospital perspective, obviously we've talked about reducing readmissions. It turns out it's all public information. For fiscal year 17, my health system apparently is getting a 0.16% Medicare payment decrement. I think if I said that correctly. So we're going to lose about $136,000 this year. Fortunately, I don't have to write the check, I hope. And I looked around, other places in San Diego are all the way from 0% up to 0.88%, something like that. There are some places that are going to spend about $1 million in penalties. That's real money, even for multi-million-dollar businesses. Improving throughput, ensuring that services are available because you have better throughput, those are definitely opportunities for community paramedicine. But what about the risks? Right? Because we got to be honest with ourselves from, if you're looking from this at the standpoint of I'm a hospital, I'm trying to stay in business and provide health care to people, how does this present a risk to me? Well, if patients go elsewhere, it's a loss of revenue, potentially, fragmentation of information, and as we discussed earlier, but can't stop considering safety. So the loss of revenue portion. It makes sense, at least I should say it's intuitive, that if less patients come in, less money comes in. And yeah, there's some potential offset, right? If we decrease the readmission penalties, well, that's $136,000 we could have gotten this year to pay for performance penalties. But I got to admit that although we will apparently charge them quite heftily, the not-so-sick patients, they're still a revenue source. It doesn't cost me a lot as an emergency department to take care of somebody's sprained ankle. I'm still going to bill them for it because that's how we work. We're already staffed for anything and everything. So the truth is that marginal cost is not a whole lot, and that is a potential loss of revenue. So is that a deal breaker? Not really. I don't think so. Because when you consider the value that we can be providing to patients through a community paramedicine program, the value that we're receiving from those programs, as some of the previous presenters have mentioned, which is going to be quite a bit of money, but also a better handle on their patients, then maybe that loss of revenue isn't really so much. And if we do weed out some of those patients that don't really need acute care services, because remember, we're talking about general acute care hospitals, acute care, that's what we do. If you weed some of those folks out, there's a little bit more room for people who maybe do need those acute care services, which incidentally probably could generate more revenue on those folks anyway. And there is the potential that we could partner with community paramedicine agencies. We can provide new service lines. There's no reason why we have to be completely separate silos. We can work together. What about fragmentation of information? There's no question that there is some potential that patients are going to be seen off of our turf, outside of our territory, at an urgent care belonging to another health system, to a provider that doesn't integrate with our electronic health record, anything like that. And we all know the reasons why we get people to their medical homes, and a big part of it is to try to reduce costs related to duplicative care. Oh, I didn't realize you had a CT scan yesterday. That type of thing. Well, it is unfortunately difficult to share information between hospitals and EMS agencies. It's it's better in some places than others, but hospitals don't always have access to that care plan. One of the things we discussed, that Ann had mentioned for the Resource Access Program, is that we put together care plans. Well, the hospital's not always going to have access to that care plan. The primary physician should, but they may not be, their office might not be open. They may not be able to deliver that to the hospital. So the information can kind of get split up. And yeah, that is a risk. And I think the way to address that from a hospital standpoint is, frankly, we need to get ahead of it. We need to know that we have regional health information exchanges, like the one here in San Diego. San Diego Health Connect is really proactive in reaching out to every site, every agency that might provide patients, receive patients. We're tying into counties that, places outside of San Diego. We've got all the family health centers, and they're really doing their best. And I'm glad to see that we're finally working a lot better on EMS integration. And one of the things that's always difficult to accept is that while we do have to respect HIPAA, the California Confidentiality of Medical Information Act, and probably about a solid 18 inches of statutes and regulations, we have to make information sharing the norm. We have to say, we are used to the concept, we are going to share information between us, EMS agencies, social service agencies, other health systems, rather than making it some difficult to reach thing where you have to get the form signed, you have to find the house supervisor, they have to go, with the big key and unlock medical records at 3 a.m. It can't work that way. And it doesn't work that way. And safety. And as a physician, I got to admit, it is hard to give up control. There are times I totally wish I could give up control, but when it comes to something as important as our patient's health, sometimes I feel a little weird saying, okay, I'm going to admit you to the hospital and I'm going to let the cardiologist take care of your heart attack. I mean, of course the cardiologist should take care of that heart attack. Lord knows you don't want me doing my very first cardiac catheterization on you. But it's still a little tough to say, okay, we're done, and I'm moving on to, and that's to someone that I know. Concerns there's always concern about liability. If we don't know our community paramedics very well, if maybe some people in hospitals aren't entirely sure what a community paramedic is or what they do, it makes that willingness to transition care just a little bit tougher. So I think that one thing we've seen through these pilot programs is that safety is definitely still being protected. We know that quality assurance is absolutely happening, and we need to make sure that that continues to happen, right? Hospitals sometimes think like, well, we should do all the quality assurance. Sometimes like, well, we don't want to get involved in anything that happens outside of our territory. We got to drop those walls, right? We've got to say we are going to do vigorous CQI and QA, and it's going to be omnidirectional. It's not just that we tell everyone else what they did wrong. We look at ourselves, we have other people look at us, we all work together. If we can do that, and again, that involves a lot of partnership, then we are still working on the side of patient safety. And part of the way to do that, which is, again, not entirely traditional for us, is to work, certainly we do community efforts, but as hospitals, I feel we need to step out more into joint educational opportunities. You want to make sure a community paramedic is trained to a certain level. Go out to your local community paramedic education place and offer some services to say, this is how we would like to help. Make sure that care plan discussions include all the stakeholders. And of course, if there is some immediate care concern with a patient being cared for by a community paramedic, then you've got to have a single point of contact to manage that. As far as I'm concerned, that's the EMS medical director because they're already set up for that. But from the hospital standpoint, it might be a little weird to say, let's put this on someone who might not be affiliated with our health system. Fortunately, I think what it comes down to is there are a lot of benefits to hospitals. When I look at this through my business eyes and my large organizational, rose-colored glasses here, there's no question, right? If you reduce healthcare costs, it's better for the patients, it's better for providers, it's better for business. And I think that potential loss of revenue, like we discussed, we're going to make up for that. But another big part of it is that if we can provide effective and realistic alternatives, right? If we can do things for patients that right now we can't, that makes the patients happy. It makes us happy. If you make me happy, I probably work better. And although it's hard to put a dollar amount on that, I'm sure somebody can. I think that's a consideration that's pretty important that we should not overlook. More from the strict business standpoint, there's a very marketable message when you say we're working with our community to provide improved health and wellness, especially when a lot of health systems are trying to reach out to more rural communities, places that are underserved. I was reading earlier that apparently only 5% of California is actually urban, something like 81% rural, 14% wilderness. Now, of course, in that 5%, we have 85 to 90% of the population. But even in there are a lot of underserved urban populations that we could reach out to a whole lot better. And frankly, a benefit, we talked about, Kevin, what was it? $1.2 million saved and not a single dollar of cost to the hospital. That's pretty awesome from a hospital standpoint. So awesome, in fact, that in order to sustain that, we might need to consider providing some financial support, such as in North Central Texas, so that these community paramedicine programs that are helping us and our patients can be more easily sustained. So, yeah, I think we can affect these outcomes. I think from the hospital standpoint, community paramedicine has a lot of value on both the triple aim and the 6 Ds. I think those are things that we can make better. So where's the next step for us? One, data. We absolutely have to provide data to make sure that we can do research in a meaningful way. If you want to find out if every person that gets seen by paramedic X ends up dying 20 days later, you're not going to know if you don't have the outcomes data. Eventually the coroner will come tell you, but and obviously that's not the type of thing that we're looking for. But that really, I think, helps to drive home that point, right? We need data, and we need it to flow not just from the EMS agency to the hospital. As a hospital, we've got to work with our other healthcare providers. We've got to see what our resources are. Needs assessment, is one of those things we discuss in public health class. It's always useful, more so if you've done it before you've already developed your program. I did hear this word recently, co-opetition, to describe the state of San Diego County healthcare. And I decided I don't like that word. But it does, I think, at least sort of demonstrate that even when we are saying, well, we want to make money, we want to get more market share, we want to be considered the best health system in the region, we still need to remember that to best take care of our region, we may need to be sharing some of our resources with community paramedicine programs, working with other hospitals to figure out the best way to provide, scant resources to populations that are difficult to reach. And absolutely, we've got to work with EMS, we've got to work with regulators and legislators to discuss appropriate reimbursement plans, because if we can't pay for innovative delivery models for healthcare, they're not happening for long. So I think the summary for that is be open to innovation. Don't be afraid of change just because it's changey. Obviously, continue to champion patients' healthcare, and their health has got to be the primary concern. Even if we have to redefine success from, what does it say on the balance sheet to what are the health outcomes that we're meeting? How are we getting closer to Healthy People 2020? That type of thing. And absolutely, we need to recognize and respect our professional partners out there that are doing amazing work. Speaking of our partners, I want to say thanks to the California Hospital Association for letting me take up about 25 minutes of your time, as well as the California Healthcare Foundation and the EMS Authority, and for putting this on. And if you have any questions, I'd be happy to take them.
BJ again, and I just wanted to thank Chris very much for punting in at the last minute. I was supposed to be somewhere else today, and Chris graciously picked up for me, and I think you did a fabulous job. And I hope he was able to share with you the sort of ambiguity that hospitals sit in. But as I said earlier, we are in this with you. It is not you and us. You know, it's not us and them. It's all of us together working at this. So thank you very much for the message.
I'm glad to do it. And there's definitely a lot of incentives out there, and I think we may find that they are many of them are more aligned than we give it credit for, and we just have to be willing to admit that and work on that.